All right, welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Brian Waterman, a sports and shoulder surgeon at Wake Forest University in North Carolina. I'm joined today by my co-host, Peter Chalmers, shoulder elbow surgeon at the University of Utah in Salt Lake City. Peter, how you doing on this fine day?
Oh, I'm doing great. I'm really glad to be here and get this episode started.
Yeah, I should say before we get started, I'm going to mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. With that disclaimer out of the way, I certainly want to usher in this episode. Baseball season is in full swing. We've just witnessed the pivotal Game 3 of the College World Series, of which Kevin was fortunate enough to be in Omaha, and we certainly see that Major League Baseball is running at full blast. Today, in honor of that, we've got a great episode on the pod to explore critical issues around the overhead athlete. And we specifically want to focus on that throwing shoulder. To my mind, there's nobody that's better to broach this topic than two good friends and really mentors that have an incredible background in the sport. Both are dual fellowship trained in sports medicine and shoulder elbow surgery, and both competed at a very high level as athletes themselves. First, from Stanford University is Michael T. Freehill. Mike, welcome to the podcast.
Thanks for having me.
Next, from Gainesville and the University of Florida is Kevin Farmer. Kevin, thanks again for joining us today.
Hey, thank you very much for having me. Excited to have a nice discussion tonight.
So I want to go ahead and establish your street cred early. I've learned an incredible amount from both of you on the topic, how to approach the elite thrower, and a lot about the game of baseball. I wanted to kind of set the stage a little bit. Tell us a little bit about how you are currently involved in a leadership capacity or team physician role at your respective institutions. Mike, you want to get us started?
So team physician-wise, I'm the head team physician for the Stanford baseball team with regards to baseball. And then I'm the assistant orthopedic surgeon to a guy named Will Workman, who's been doing the A's, Oakland A's, or the soon-to-be A's only, for about 12 years or 13 years. So two of us do them.
Fantastic.
Yeah.
Kevin?
Yeah,
Your
so
Florida team is a perennial mainstay in Omaha. Tell me about that and any other roles you currently play.
so I've been at the University of Florida now. I think this is going on my 15th year. We have had a nice run. So I've been fortunate to personally been to Omaha 8 times. I think been there 9 times since I started, and won it once. Been nice to win it more. Made it to the Final Four this season, which was more than expected. And certainly has been a highlight of my career. As you mentioned, both Mike and I played baseball and played in college, and Mike played professionally. But to have the opportunity to work in this field and with these athletes certainly has been a dream come true for me. And I grew up a Gator fan my whole life, so having this opportunity for me has really been a blessing. And obviously I'm also involved at the high school level. I'm on the Florida High School Athletic Association Sports Medicine Advisory Committee, so I've been involved with working on pitch counts and rules on a state level to try to keep athletes safe, and kind of working in the grassroots in that as well.
Which is huge. And I think in many cases, when we have all these discussions about throwing related injuries, very often it's all about slap tears and UCLs, and it just seems like it takes all the oxygen out of the conversation. But as you know, there are so many other conditions that lead to shoulder pain in the overhead athlete. And I wanted to see if we can kick off on a discussion about the evaluation of internal impingement. Maybe, Kevin, if we could stick with you on this, talk to me a little bit about your approach to these patients. What do they look like? What are you evaluating? What guides your treatment and decision making?
Yeah, it's a difficult problem, and one that I'm seeing a lot of. I think this week I've seen 3 or 4 high level pitchers with internal impingement that I've had to manage as far as expectations. They often complain of that deep seated posterior shoulder pain, kind of in that late cocking phase. One thing that I've evolved over the last couple years of my career is realizing that the role of the anterior capsule, and I've had several, and we may get into this more, but several anterior capsular tears that presented all the world, like internal impingement with the posterior pain and the findings because of that increased external rotation that causes that contact. But yeah, so the first thing I look for is kind of the description of the throwing phase. I think I tell all of our residents and fellows to understand the phases of throwing. I think that's critical in these athletes to work through when do they complain of pain, at what point in the throwing phase. Obviously, they don't know the terminology like we do. They're not going to use the term leg cocking, but they'll talk about their arm being far all the way back. That's where they feel it, and they'll complain of that posterior pain. I'll examine side to side. Rotational comparison. They often have excessive external rotation, which is sort of the hallmark of that internal impingement, and obviously they tend to have a loss of internal rotation, which sort of adds to it. So certainly understanding the phases of throwing, understanding that where their complaints are, and then understanding their evaluation as far as rotational side to side comparison is sort of where I first start. It kind of draws me down that path toward a diagnosis and a plan as far as imaging and all those things.
That was great. What about you, Freehill? I mean, again, you've had a lot of personal experience and then professional experience with this. Do you think internal impingement is just the expected outcome of the activity of pitching? Are there modifiable risk factors? I guess my question for you is this a price to be paid, or is this an actual pathology?
It's interesting, right? Because if you talk about internal impingement by just a definition, you would probably, I would probably say at its most grassroots, it's probably what Jills Walsh described first in tennis players, and that's your humeral head moving in a posterior superior direction, kind of grinding up against the posterior superior labrum, which is wedged between the head and the inferior portion of the anterior infraspinatus usually. So that's kind of your area of internal impingement. But I think Kevin said something really interesting because, what drives it? And I agree, the Curl and Jobe thought process back in the 1990s and even in the 2000s it was a laxity problem anteriorly. And a lot of individuals who have a lot of hyperlaxity, especially with external rotation, have the ability to have a longer arc of motion and at baseline could probably throw a ball harder. And I mean, I remember when I got drafted and Lou Yoakum, and he was obviously, you guys probably know Lou Yoakum, that was at Curl and Jobe, and he took care of the Angels for a long time. And when he did my exam, he's like, yeah, your shoulder is super loose. It allows you to do things that a lot of people can't do, but you have to be really careful. And it's interesting because I think what Kevin said is true, and I think it gets missed a lot, or is these capsular rents, or how much the capsule is stretching out. And does that, so when you slide, do you slide forward and then come back? And then, that was what was the start of all the thermal capsulorrhaphy that was going on in the late 90s for that reason. But then you got into the early 2000s and this, six scapula came about with a 3-part arthroscopy with Burkhardt and Kibler and Morgan. And they started getting more into the GERD and the scapular dyskinesia, and then does GERD move the humeral head posterior superior, or is it scapular dyskinesia and a tight pec minor that's causing the humeral head to shift abnormally? So, it's interesting. I think that all those things, if you do an exam, you pick up one or multiple deficits anywhere in the kinetic chain, quite frankly. And could those be leading to what we know as internal impingement? And my thought is it is.
Can I push you just for a second about range of motion? Because I've heard both of you talk now about GERD, loss of internal rotation, excess external rotation. This is my question. On exam, how do you, Mike Freehill, you have a patient in front of you, differentiate what is adaptive humeral change that's happened because that player is through skeletal immaturity and has remodeled himself into humeral retrotorsion, and what is capsular laxity that may be in excess. Like, how do you figure that out when you actually have the patient in front of you? Are you doing ultrasounds? Are you comparing range of motion measurements that you have like from the trainer at the beginning of the season? Like, how do you actually figure out when those things change over that player's, altered humeral osseous anatomy baseline?
Yeah, so that's a good question. I think so. I do enough of them that I don't feel like if we're doing a study or something, you'll use some kind of goniometer and lay them down. But generally speaking, I think that I have a pretty good, intra class coefficient on myself that I do it enough that I can get within 5 degrees on each side, at least in my own the way I see it. Obviously that might be different, but I don't see as much of the hyper external rotation as I used to see. I'm actually seeing some of too little, which I think is concerning and we can go into later. But I will tell you, Peter, and I know there's arguments about this. If you're moving somebody gently and you're making sure that they're not contributing with their scapula, but just getting internal rotation at 90, and they have 45 to 60 on their non-throwing arm, and they can't even get to neutral, or they're just at 0 on their throwing arm, that's not humeral retrotorsion. I mean, maybe it is, but I don't. That makes zero sense to me. Like, I think that exists, and I think that if your physes don't derotate when you're younger because you throw the ball a lot, which probably independently assorts you into whether or not you're going to be an overhead thrower or not. But I don't. I find it hard to believe that you're have so much retroversion that you have a GERD of 0. Now, maybe you do, but the bottom line is you're going to, uh, have their posterior capsular stretched, and if they correct, then that's a posterior capsular issue. They were tight, and the literature would support that you can do that usually. If you can't, then what I usually do is look for some reason, and high on that differential be like a Bennett's lesion or something of that sort. But I'd love to hear what you guys think and what Kevin thinks, because the humeral retrotorsion, I think, plays a part in it. But there's a big push to say GERD is dead, and I don't know if that's necessarily true, at least in my mind. I totally respect the total arc of motion. That's very important, as important or more important. But certainly, if you have internal rotation of 0, that's an issue to me.
Yeah, I would agree with what Mike says. I think the posterior capsule still plays a large role. I don't quite understand this push that to get away from the sleeper stretches. It seems like in the athletic training world and in some physical therapy world, there's this push to get away from that, and that to me inherently doesn't make as much sense. Maybe I'm missing something, but I certainly see a lot of athletes that I feel like still have posterior capsule tightness that is part of the pathology. And then, Peter, to answer your question, I basically do the same thing Peter does. I'm sure very similar to what you got. I really try to nail down how much of the motion is capsular motion. And I think that's difficult to tease out for, especially with residents and fellows and trainees to identify that. You really have to put your hand on the scapula. The minute you feel the scapula start to move, you know that you've surpassed your capsular motion. Now you've gotten into scapulothoracic motion, and trying to really identify that where that happens, I think is a critical point in truly understanding the glenohumeral motion and what's more complex motion. Because as you mentioned, the humeral retroversion I think is a part of it, but these tend to go way past that, and that preserved arc of motion that you see because of the retrotorsion. I think that it's that excessive external with the excessive loss of internal that I think differentiates it to it in my evaluations.
Yeah, both of you allude to kind of the sorcery of physical examination of the overhead throwing athlete. And you offered some incredibly nuanced takes on how to identify where that motion comes from, where that endpoint is, how they've compensated for it, scapular position. So let's fast forward a little bit, and we're talking about internal impingement with the partial articular rotator cuff disease. It's definitely one of the more troublesome things that we see, especially when it's failed to respond to conservative treatments. Kevin, maybe we stick with you. What's your next step if therapy has failed? Are you doing an intra-articular injection, lidocaine challenge, steroid? Is it something that you are confident that surgical treatment can address this? Walk me through this.
Yeah, that is a very difficult patient to manage, in my opinion. So I think timelines matter. We had a guy this season that was an important player in our team and had this and didn't have any striking pathology that I felt like needed to be out for extended period of time. So I think in that setting, towards the end of a season to have a pitcher that plays a major role that maybe you can get things calmed down over a course of 2 or 3 weeks. That's probably the one setting that I would consider an ultrasound guided glenohumeral corticosteroid injection just to get over the hump and calm down and some inflammation, and then see after a couple of weeks of rehab where they are. As long as you are confident that that you evaluated the pathology and you're not worried about any other further injury risk or things along those lines. I think that there is a role there, but I think if you have time, my next step would usually be a biologic type injection. I really think that the humeral head edema and the humeral head cyst is an underappreciated source of pain in these athletes. I akin it to a subchondral insufficiency fracture, and I think that's a major source of pain that we overlook. And so if they have humeral head edema, I've gotten pretty aggressive on biologic injections, even into the humeral head area. Yeah, I've done iliac crest bone marrow injections into that area. I've done PRP. The couple this last 2 week we did PRP intra-articular to try to calm down the biologic issue. I think because I do think that humeral head edema is a large source of their discomfort, and if you don't resolve that issue, that they're going to continue to have problems. And so that's typically my next approach. They almost always have posterior labral pathology on their MRI, and you have to kind of tease out whether or not you think that's adaptive versus pathologic. Chris Ahmad just gave a nice talk at the ANA meeting and opened my eyes that maybe we're getting too aggressive on fixing these posterior labral tears because these are adaptive changes in a lot of these athletes. And how do you distinguish somebody who has an adaptive posterior labral kind of wear and tear versus someone's got a pathologic posterior labral pathology, and whether or not they need to have that addressed? And so I've gone the way of a lot more biologic approach in this particular population, and I think the jury's out. We'll see. We'll see if it's successful or not. But that's been my evolution over the last couple of years.
Yeah, it's an interesting concept, and certainly I agree with you. It's definitely relevant in many other areas of the shoulder upper extremity. The critical threshold above which you do something other than a debridement is always up for debate. Mike, what degree of partial articular-sided debridement will you allow before start talking about doing the dreaded takedown and repair or an articular-sided repair? Is there a number that you have? Is it 50%, 70%, near 100%?
No, there's not a number, but I'll tell you, you know, I'd be very, I don't really repair the rotator cuff and tendons and the throwers. And, certainly I don't have the cohort that, Dr. Andrews or, that some of the others with the really, really high volumes that have published on. But I haven't seen that many. I think that if you're 50% or below, that the right thing to do is debride them. And I think the literature would support that too. I just think it's tricky to repair that population and have a predictable. And I think the other thing that supports that is when you look at certain classic papers in the literature, like that Pat Connor paper that talked about, I think they had 20 asymptomatic overhead athletes and did MRIs on them and the findings in them, with all the, especially with the cuff findings were crazy. I mean, they had high grade partials and everything else in there. And these were people that were throwing fine. So I don't, my own take on that is debridement. I might change that if I have some almost full thickness tear, but that's just what I do right now.
I think that those are wise words, Mike. I think what you say about how commonly we have pitchers that are pitching through this pathology really the elephant in the room with all of this is understanding, what you see on an MRI in a picture. How can you understand what's pathology and how can you understand what's adaptation? Like, for instance, with discussion of humeral head edema, like we did a study, this hasn't been published yet, but we did a study looking at 200 MRIs that were done as part of the combine, and 21% of them have that humeral head edema. So, like, can it be painful? Of course it can be painful, but how do I figure out then if 20% of people normally have it when it is or is not painful? So I love your approach of Kevin Farmer injections, maybe to try and figure out who is or is not maybe symptomatic from that. It's definitely, I think, something we just have to, it just takes a lot of the experience you guys have with these players to try and figure it out what's pathology and what's normal adaptation. I want to chat with you a little bit about that with the labrum, because I think this is what, and you mentioned earlier, Kevin, we see a lot of posterior labral pathology, hyperplasia, fraying. You can even see glenoid dysplasia, other adaptive changes. You can even see the Bennett's lesion, and this is this kind of traction exostosis. So I wanted to ask you guys both about this Bennett's lesion, because I've seen it. I think you guys have seen it. How do you figure out whether it's incidental or pathology? And is it something you can leave alone, or is it something that you have to address? So what are your thoughts, Ken Farmer?
Yeah, it's again, it's always the other issue is what I call the pre-Bennett's lesion, which I've seen more and more of, and that's this kind of stripping of the posterior inferior labrum and capsule. I think prior to ossification, it looks all the world like a reverse bank card, but I think it's just what the findings of what leads to a Bennett's lesion. But they had that study, I believe it was the Cardinals, where like you said, they looked at the X-rays of during the preseason physicals, and I believe the same number, 20% of the Cardinals players had Bennett's lesions, and so I think I address a Bennett's lesion like I would somebody with GERD. If they've got symptomatic, if they've got symptoms with a very tight posterior capsule and a Bennett's lesion, I think those things kind of run hand in hand. I think the Bennett's lesions, Bennett lesion is a presentation of due to capsular traction and the tight posterior capsule in relation to that's failed non-op management. I think again an injection is worthwhile to consider in some cases, but if they fail non-op management and they're a tight posterior capsule, then a posterior capsule release in addition with a takedown, I think Keith Meister published that data 20 years ago, can be successful, but I think it's more the posterior capsule release than it is the approach to the Bennett's lesion.
So when you say takedown, like, do you mean you're taking the bird or the back of the glenoid? Just describe for us how because I've done these cases. I think they're very hard to figure out when you're done. How do you know when you're done?
It's not gratifying at all. Yeah, it's a good question. That's one of these, you can't get great X-rays, you can't get imaging. So I Gestalt, I don't have a great answer. I just kind of go a little bit, look at it, see how it feels, palpate, try to get it, symmetric with the remainder concavity or curvature of the posterior glenoid. But you're right, it's not a satisfying approach because you're always kind of second guessing yourself along the way.
Mike Freehill, any additional words of wisdom when it comes to the Bennett's lesion? Please teach me, because I feel like I have a lot to learn about this.
When I was in my shoulder fellowship, we had a thrower with a Bennett's lesion, so that kind of sparked my interest because I didn't know much about him. So we did this kind of big systematic review that took years to end up getting published, and we made a classification system. I don't know if you've seen this in OJSM, got published a couple years ago, and it was based off these findings, right? So going back, where Kevin and I both trained at Hopkins, Bennett was actually an orthopedic surgeon there. He was the first one to describe it. Did you know that, Kev?
I know it from your article. Yeah, I learned that.
But anyway, what we noticed, especially with the literature from Japan, because they have so many throwers, was probably where 75% of the studies were from. And when we started looking at all these different papers, you started to notice that although the original was down by the triceps tendon, the one that Bennett described, and we usually think like posterior inferior, that there were some straight posterior and there were some even posterior superior. And Burkhardt even described, an exostosis underneath the superior labrum that he called a pitcher's mound. So that was the first thing. It's like, wait a minute, we're kind of using, are these all Bennett's? Are these not? Or, can they all cause changes? And then what we saw that was even more interesting was they started describing these exostosis or these Bennett's lesions that were either attached or fragmented. And that made me start thinking, because when you looked at the exams of those two types, it was like Kevin said, the ones that have an attached Bennett's lesion, they tend to have the GERD. They're not always painful, but they have GERD. If they have a fragmented or fractured or whatever Bennett's lesion, they don't have a loss of motion, but they tend to have the pain. So I'm not so sure that these don't start as traction exostosis that are like an osteophyte, and somewhere along the line, either from banging into it or from traction pulling it, it fractures. And the presentation can be either. And to get to my algorithm, I've had a couple in the last month actually, is you can do an injection to rule it, like definitively rule it in, and with a little bit of steroid. I haven't used PRP, but a little bit of steroid. We had a Stanford pitcher a couple years ago. He had it, and he got symptomatic, and it was a fracture fragment. We injected him in like February, and he got through the whole season. But then the symptoms started coming back, right as the season ended, and we said, let's just go get it. Then the caveat to that, when you go after it, is the posterior labrum intact or is it not? And sometimes the posterior labrum can be torn. If it is, you can go in that plane. If the posterior labrum's not torn, which in my small n of these operatively is usually the case, then you do what Kevin said, and you're going through the capsule to get down to it. You can't view it from high anterior you have to be like, you have to work like next to where your camera is to see down around that rim. Just like you guys said, it's hard. But once you buzz down, and same thing, I use a switching stick and kind of feel, is that gone? But once you get rid of that bony exostosis, then you leave the capsule be. It's not like a football player that, you might repair the capsule on your way out, because I think that you've probably addressed some of the tight posterior inferior glenohumeral ligament with the repair. Sorry to drag on, but it's an interesting topic.
Well, I like the idea you kind of put out there about an unstable versus a stable Bennett's lesion. I never thought about that, but there's certainly, I understand there shouldn't certainly a difference between the two based on your kind of description there. That's a good point.
Yeah, and Mike, and this is sounding dangerously close to a hip scope at this point in time, which, this is the art, right, of the Bennett's lesion. And I've read your paper, and in fact, I've taken a deep dive on it as well. And I think that there's so little data. There's a lot of room for us to band together and kind of develop more global algorithms. But I like your thought about the diagnostic and therapeutic injection. That's certainly something that's been described by Allcheck, and there's some other very limited series, and then there's the Journal of Anecdotal Medicine, which I think motivates all of us in how we manage this. Maybe we take a step back and talk about something that's a little bit more concrete, and that's the dreaded batter shoulder. Kevin, can you introduce the audience to this concept and maybe how your management is a little different than the Bennett's lesion, different than the traditional shoulder instability? What's your success with non-operative rate? And then maybe we can dig in on a couple of the specifics thereafter.
Yeah, so a batter shoulder, it is effectively a posterior instability of the lead shoulder in a hitter, and the belief is, and it kind of depends on who you ask how it happens, but I think my belief is that it usually happens during the initiation of the swing. EMG studies show there's kind of a rapid concentric reaction of the posterior cuff as you initiate the swing. And you get this kind of direct, if you think about your lead shoulder as you initiate moving towards the pitcher, there's a posterior directed force on the shoulder that can lead to posterior instability. Some people think it's the follow through that it can happen, and certainly I think it could be the combination of the two. But you get this posterior instability of your lead shoulder. MRIs show a posterior labral tear, very akin to a posterior instability in a contact athlete. And most cases that I've seen, it can be very symptomatic, and I have not had success with most cases with non-operative management. You see a lot of these players on TV where they take a swing and they drop to a knee. That's almost always a battered shoulder that in most of those cases. And you'll hear about taking a week off or 2 weeks off for the DL, and then next thing you know, they're having surgery done for the season. That's been my experience, is that in these big swingers with these high velocity swings, that having your lead shoulder being unstable is tends to not be a recipe for success, and in most cases those end up needing to be fixed. And certainly you got to be careful, because I've seen that they're often and it can be multi-directional. So I've seen a couple where I fixed them posteriorly, and then even afterwards they end up having some anterior instability issues that maybe I could have been more aggressive with my anterior anchors as well. So I think it's described as a posterior instability of the lead shoulder, but in my experience, I think it's more of a multi-directional instability of the lead shoulder, just due to the energy related and the velocity to with the swing.
Yeah, and Mike, help me to understand. Am I doing an in situ labral repair? Am I taking a little bit of capsule? Am I titrating to effect? How is this for you when you're doing a repair on this patient?
Well, first of all, I'm the same as Kevin. If these to me, these don't do that well. Now, where they get tricky is if, say, the guy throws right-handed and he hits right-handed and he has a left shoulder posterior labrum, batter shoulder. You know, I they're going to get it fixed. The question is, where are you in the season? Can you somehow get through? Can you modify the swing a little bit? That's not so easy as you get into higher levels, but they're going to get fixed. The problem becomes when they're a left-hand throwing outfielder and they hit right-hander, or they're a switch hitter, because the throw, now you're mixing in uh, the treatment gets different to me. So if you have a left-hand batter shoulder but you throw right-handed, I would do it. I probably I don't. I always grab a little bit of capsule because it's thinner. It's only a third of the anterior. Um, Maybe not as big of a bite as like a football player, because I grab a little capsule with that. But I do grab some, because yeah, if you look at some of like Kevin said, some of the bigger guys that are getting it now, I think I don't know if that's interesting. You brought up, Kev, that kind of co-contraction, and if things are firing, because I think some of them, it might get back to almost our internal impingement talk, because I think some of these guys, and them like Tatis and Chris Bryant, them powerful swings with huge one-hand releases. So I don't know if that's more of a degenerative, like number of repetition loads versus that one that you're talking about, where you like swing and miss, you get that weird like air ball that the humeral heads flying through there. And I think that was kind of the description that Josh Dines made in what I think is the original paper from HSS. And but to go back, if it's not their throwing shoulder, I grab a bit of capsule. If it's their throwing shoulder, no.
Yeah, you mentioned the write up. It's funny. Everyone says Andrews has talked about this forever, but it had never been written up. I think Dines wrote it up. I think we have a case series about 11 or 12 that we wrote up, but Andrews never. Yeah, it's not in. It certainly is not in AJSM or anything like that. But we have a case series. But Andrews is famous for talking about it, and all of his fellows who've come through all know about it. But it was never really written up or described until probably the last 10 years, which is kind of surprising.
Yeah. I
We
think
really,
it's on the rise. I think it's a diagnosis that's going to be on the rise, because guys are getting bigger and they're getting stronger. It's kind of like we were talking about, Peter and Brian presented on the lat stuff. Guys are throwing harder. So I think there's certain pathologies that are starting to present more than we saw over a decade ago or 2 decades ago.
Yeah, I completely agree with that. We've talked a lot about the back, the posterior labrum, the Bennett, the back of the cuff. I wanted to get to the front, and we hinted earlier that there's these patients that have capsular tears, even, sometimes even involving the lower subscapularis. I've seen these. I think that you guys have both seen them. I wanted you to talk a little bit about when do these occur? Are these traumatic? Do you think that these are kind of like a micro trauma instability? How do you diagnose them? How do you treat them? Maybe Freehill, maybe you could start with us and cover this problem, because I think it's not well described, but it definitely exists out there.
Yeah, I think this gets back to that hyper-external rotation. I think, I mean, I have kind of a bias against like how people are utilizing weighted balls that are heavier than a baseball. It's one thing to use balls in a controlled, like closed setting, where you're doing muscle memory and you're building some strength. It's another thing to take a ball that's heavier than a baseball and try to throw it, as hard as you can. And I think that causes additional external rotation. And while that might seem beneficial, you know, initially, I think that can lead to that would be one mechanism of injury where you're really almost twisting that anterior capsule back. And I think the others are just those that have more range of motion. So that's where I think you see it. Um, but it's hard to diagnose. Again, when I first got to Stanford, we had a pitcher, a high level guy. He's in pro ball now, and we couldn't figure out what the heck was going on with him. And we we have be talking to John Conway, and he said, "I bet you this whole presentation sounds like it's a capsular rent, and it's probably there, and you can't see it." And that's when you get into this, ropivacaine or lidocaine or whatever kind of litmus test, if you will. Have them irritate that arm a little bit with throwing and put it in the joint and see what kind of relief they get. And and we did that, and I think we repeated the imaging and it kind of looking, but it was there, and then we went and fixed it, and it was real, and these will heal. These aren't something where you have to go crazy with the repair. You just need to reapproximate the capsule. To my again, I have less than 10 of these, but like but they tend to do okay if you identify it and address it.
When you say reapproximate the capsule, are you like arthroscopically stitching it back together? Or are you putting anchors in the humerus? Tell us how you fix these.
No, I mean, I can't remember who presented. It might have been one of you three, but someone presented a case like this, and it was almost like it wasn't. It was a capsular rent, but it went all the way up onto the humerus, so it was almost like a haggle type of variant. But I haven't had that, so I don't put it. I'll just go side to side. Just take a rasp and roughen up each side of where the split or the rent is, and then pass 0 PDS, and that's arguable too, using that. But I think it's less abrasive and it will dissolve and or reabsorb and they do okay.
What about you, Kevin Farmer? Is this similar to your approach?
Yeah. I mean, I tend to end up almost doing a baseball type stitch, a running stitch using either PDS I've used a non-absorbable high strength stitch. Neil Eltraj has got a video of doing one where he ran a baseball stitch and then because it split all the way down to the labrum and then anchored that part down into the glenoid, afterwards. And so I think some variation. You have to be comfortable working, from both the front and the back. You have to be comfortable using lassos. You have to be comfortable with proximity to the axillary nerve and all those things. So it's not. I don't want to make it trivial that it's easy because you have to be comfortable with the arthroscopic approaches to that area. But I would say any physician that enjoys baseball medicine and taking care of these athletes, familiarize yourself with understanding capsular tears because the first one I saw, it was not very easy for me to fully understand what I was looking at. Our radiologist did not understand what they were looking at either. There are good papers. All Check's got a case series, one of the original ones, and really look at those closely because it is not a it's not a normal normal thing that you find. Arthrograms make it much more useful, but seeing a big capsular split that haggles have we've all seen what haggles look like. This is a different deal. You often catch it in that kind of sagittal plane, and you see this split tear that you're like, what am I looking at here? And I think that I've spent a lot of time over the last several years understanding this process because I believe it's velocity related. All these guys are throwing 95 plus, and you get an attritional. It goes back. The pendulum has swung back, as Mike said. We talked about years ago the anterior capsule laxity being the problem, and Oral Hershiser famously, I think, had an anterior capsulorrhaphy that was successful. But I think we focused on the back for 20 years, and now he swung back, I think, to the front. And these guys throwing 95 plus, they get attritional tears of the capsule that they start to present with loss of velocity, posterior shoulder pain. Again, they present all the world like internal impingement, loss of velocity. They get a humeral head edema, posterior labral tears. We start thinking that's the issue, and we forget about the front, and we forget that we don't realize that they've got an capsular capsular tear that didn't happen acutely. It happened attritionally, and that's the primary problem. If you don't address that, they're never going to attain that ability to generate that torque, because now you've lost that rubber band in the front of the shoulder that allows them to generate that torque to provide velocity. And so this is going to be a bigger and bigger problem as we move forward. Just like we saw the spike in UCLs over the last 15 years, I guarantee you that we're going to see more and more capsular issues because of velocity. So I recommend all the listeners out there to look at those papers and study it, because I promise you, if you see it and you're not looking for it, it is not as obvious as you think it should be. Maybe it's just me. Maybe it was just my lack of ability to recognize it. But it's just not a typical pathology that we have seen a lot, at least early on in our training.
Yeah, a great philosophical discussion, and one that has practical implications for taking care of our throwing athletes. I think that covers the coup contra coup injury pattern and has a more global approach to it. I wanted to kind of land this plane by talking a little bit about some of your ability to integrate new tech into your team physician care. There's so much exciting development in this area, and I wanted to maybe start with you, Mike. One of your great legacies that you left here at Wake Forest was the pitching lab. And that's really come incredibly to fruition. And I know you all have an incredible infrastructure also there at Stanford. I'm curious how you incorporate wearables, load management, biomechanical lab analyses, and how are you allowing that to influence your decision on athlete care?
Yeah, it's a good question. And I think that, it's a multi-tiered answer. So I think that the science, baseball science or sports tech, if you will, is moving faster than we know if it's effective, if it's safe, etc. Right? It's everyone's chasing velocity and chasing power, and so there's people want those things now. So the first thing with all the technology is you have to decide or determine, like, what can you use that is safe, and what do you use, and is there validation? So there's a number of things that we look at this year at Stanford, and they're not high tech things, but like a bio fabric type of a sleeve, and we put it through a study. Um, the Flex Grip Pro, as you guys know about, I think that's a hugely exciting technology. But again, utilizing that and doing some kind of internal studies on it, or studies on it, to see, what is it doing? Is it safe? Is it beneficial? Before you take the deep, like, plunge with athletes at this level. And I get, when you use other athletes or you have nothing to lose, I think you can do those things, but you got to be a little bit careful. I think the same thing happens with so we have, it's a little different, Brian, as you know, and I don't know what you have at Florida, Kevin, but when I came here and brought and hired a biomechanist from pro baseball, he kind of changed my thoughts because we didn't have a big structure being built like WACAD to have this lab inside. There would need to be a lot. There was a lot of red tape moving forward to do that. So we kind of switched the script and put the lab out on the field. And I think we were the first college to have the Kinetracks going on every single pitch and the TrackMan. So we were getting our biomechanical data in game. Um, and now a lot of people do that, and they have that, and over half the major league stadiums have it, and I know you guys do. But to me, that's where the really good data is. But then again, you got to go back. We're not all the way there because you can take that data and it can get sent, and you can get it back the next day. You have to have a biomechanist that knows how to decipher the data. It's not like you can be an orthopedic surgeon, even if you have a background in baseball and you're interested in it. It's not like you send that off and you get this full report. You have to have someone that can do it for you. And then you have to have a conversation with coaching staff and players, and everybody has to be on the same page of, what are you looking for? If someone has a weird mechanical flaw, but they're an effective pitcher, do you start messing with that flaw? I don't know, especially if they're healthy. You have somebody that is ineffective or has been injured and has a flaw. So these are the conversations. It's not so cut and dry. It's really exciting, but it's interesting. I mean, you got coaches, pitching coaches, biomechanists, athletic trainers, strength and conditioning, the team doctor, the players themselves. I mean, these are all the layers of fabric that have to work together to implement and be on the same page. So we're trying, but it's exciting.
Yeah, Kevin, I'm sure you get inundated with all the proposals, both directly and then through your coaching staff, a Johnny Come Lately product. How you evaluate them? How do you make sure it passes the sniff test? And maybe what are you most excited about moving forward?
Yeah, first I want to personally thank you and Mike for starting the pitching lab, such that it's now a recruiting tool. And my head coach called me out of the blue to tell me, "Hey, we got to work on improving kind of our pitching lab to keep up with Wake Forest." So I appreciate you guys adding that to my plate that I have to deal with. So thank you both very much. But yeah, it's an important part of the process. Yeah, I agree. The on-field measurements, you're looking at spin rates. I think looking at injury risk, I think horizontal movement of the baseball with velocity is probably one of the biggest injury risk things that the so-called sweeper we're seeing. Keith Meister, believes very strongly that the sweeper is the reason for a lot of these spike and elbow injuries that we're seeing, and so being able to evaluate, those who throw with a lot of horizontal motion, that it may be an injury risk, I think is valuable. We use a lot of radar in our throwing program. We use a lot of radar velocity. You find kind of what their normal max velocity is, and then use percentages based off of that for the return to throwing program. So 50%, should be this amount of velocity, and using radar as part of the throwing progression in an injury program, I think has been very beneficial. Years ago, when I first got there, I'm not a hip arthroscopist, but we had a player who had bilateral cam hip impingement that ended up had hip surgery and then ended up blowing his UCL about 10 years ago, 12 years ago. Opened my thought process on the lower extremity. So we started looking at all of our athletes and realizing that we did biomechanical evaluations and all of our pitchers. There was a direct correlation between hip range of motion and elbow valgus torque risk factors, and then the throwing cycle. And so we incorporated more of a hip range of motion, kinetic chain range of motion. Now there's been evidence with the low back. There's pelvic control information now that they've taken iPhones and putting it on a belt and looking at their ability to control lumbo-pelvic tilt, and that's been correlated with the risk of injury. So I think we're really getting down into the nuances of the entire kinetic chain, and that's something that I'm really excited for as the future moves forward, and how we can mitigate injuries by addressing the kinetic chain. And so I think that those are the things that that I'm looking forward as we move forward. We just got the university level. We just got $1 million, not we, but our field got $1 million grant from the president to boost up the biomechanics and in the artificial intelligence, the AI component of sports injury mitigation and sports injury prevention. So we're working closely with School of Engineering on developing those programs. So I think that the future is wide open to add these things to the process and really hopefully improve performance and to reduce injury, because that at the end of the day, that's what we're really all trying to do.
Well, I want to thank both of you for coming on. I mean, this has been a real it's been a real tour de force for both of you, just because it's such a wide range of topics, and it's very difficult to come on a podcast about this because, as you both mentioned multiple times, the literature is often sparse or at times directly conflicting. So I appreciate your courage talking about this, and I think your insights will be really valuable to listeners. It's about all the time we have for this podcast, so thanks again to our guests. For all of our Shoulder Number listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.